everyone and welcome back to another episode of GP Notebook TV. My name is Lisa Devine and I'm a GP in Wicklow in the Republic of Ireland. Today I'm reviewing a recent article from JAMA Network called Mpox, Clinical Presentation, Diagnostic Approaches and Treatment Strategies. This article starts by noting that the World Health Organization has declared Mpox, previously known as monkeypox, to be a public health emergency of international concern for a second time. They note that there have been approximately 200 new infections monthly in the US, and there's been a total of 60 deaths within the US since their first case. Until recently, we had no cases noted in the Republic of Ireland, but we do now join the over 118 countries where there has been a case. So it seemed like a good time to me to take a look at what I should know about this condition from a GP point of view. In this article, the authors seek to summarise for us high quality evidence which exists on Mpox, and they looked at literature all the way back from 1975 to September 2024. They included 111 sources of information. They state that Mpox is a condition caused by monkey virus, a zoonotic orthopox virus closely related to viruses initially discovered in 1958 in a colony of research monkeys. People talk about clades when discussing Mpox, with clades being distinct genetic lineage or subgroups of the virus which have evolved from a common ancestral virus. Mpox has two main clades. Clade 1 is endemic to Central African countries and is historically associated with more severe disease. Clade 2 is endemic to West African countries and historically was associated with milder disease. It was 2022 when Mpox, caused by Clade 2b monkeypox virus, spread worldwide beyond its original endemic areas. The World Health Organization declared an emergency which lasted until 2023. In August of 2024, a second emergency was announced due to an increase in cases of Clade 1 Mpox. So who's at risk of Mpox? Well, the answer to this question is that everyone carries a risk of being infected with Mpox. During the worldwide Clade 2 outbreak, transmission most commonly occurred through sexual contact among individuals who are gay, bisexual and men who had sex with other men. With Clade 1a Mpox, transmission is thought to be driven by zoonotic exposure, where the virus jumps from animal to human, and subsequent household spread. A subsequent proportion of the people infected with Clade 1 Mpox infections have been children, in fact. Mpox can be transmitted from animals to human through direct contact with infected lesions, bodily fluids, bites, scratches, contaminated formites such as linens and clothing, and respiratory droplets or aerosols. In human-to-human transition, the virus primarily spreads through direct, prolonged contact with an infected person's lesions or bodily fluids. Painful skin lesions are a hallmark feature of Mpox and tend to progress through 4 well-defined stages. Initially macules, then papules, vesicles and pustules over about 2 to 4 weeks, which crust over in their final stage. Prodromal symptoms, including fever, lymphadenopathy, myalgia, malaise and headache, can develop before or after the start of the rash. And this is tricky for healthcare professionals, as these prodromal symptoms, well, they could represent a number of different medical conditions. Symptoms such as proctitis and pharyngitis have also commonly occurred during the Clade 2b worldwide outbreak and may be a presenting symptom of Mpox. It's worth noting that the mean incubation period of Mpox ranges from 2 to 21 days, and people can have an illness which can vary between mild and self-limiting, unfortunately, to severe and life-threatening, especially in those who are immunocompromised. Mpox complications include necrotizing skin lesions, which can then develop bacterial superinfection, pneumonia and encephalitis. Patients diagnosed with Mpox receive supportive care, such as pain management for their lesions, hydration, nutrition and treatment of secondary infections. At the time of writing of this article, there were no specific FDA-approved treatments available for Mpox, although some antiviral therapies were being trialled. The article also noted that there were 2 FDA-approved vaccines available for Mpox, although access has been limited even in low-income countries with higher rates. As GPs, I think the important thing is to have an awareness of Mpox and follow local guidance. Our local guidance here in Ireland from the Health Protection Surveillance Centre suggests when assessing clinically ill people, we should remember to take a travel history and to consider whether or not Mpox could be in the differential diagnosis. Where suspected, we should offer isolation advice, use PPE for assessments, and seek advice from local infectious diseases or microbiology colleagues. It could be worth having a look to see if there's any local guidelines in your area where you're practicing, or see if there has been any cases. Overall, I think this article gave a great, easy to read overview of up-to-date information on Mpox, and I certainly feel my knowledge base has improved after reading it. I hope you find this video helpful, and I look forward to seeing you soon again on GP Notebook TV.